series, I am Joe's heart, I am Joe's kidney, I am Joe's liver. And after we read, I am Joe's liver, I never ate liver and onions again. Because I knew what the liver did. And no matter how much my mother wanted me to eat it, you could forget it. Basically what it does is it metabolizes and breaks down toxic waste. It breaks down blood vessels. It breaks down a lot of things that the body needs to get rid of. It also metabolizes protein, carbohydrates, and fats. Okay? Remember, this is where albumin sort of is produced. So that if you have someone with liver damage, they typically will have low albumin levels, which can lead to what, guys? Acidic fluid or ascites. Okay, because remember they have a problem holding fluid in that intravascular space. The other thing that the liver does is that it helps to absorb and store your fat-soluble vitamins. A, D, E, and K. So what's vitamin K good for? Clotting. Okay, so people that have liver damage of some sort may have clotting issues. Okay? Basically, what you're going to see is that the liver mainly is located in the right upper quadrant of the abdomen. The left lobe is in the left upper quadrant. Typically, what you're going to see is that whenever they do palpation or deep palpation to check the liver edge, they're going to have you to take a deep breath. And then they're going to sort of push up to see if they can feel the edge of the liver. Okay? Typically what they should have to do is to push up. People that have enlarged livers, often they're able to palpate without pushing under the rib cage just a little bit. What you see is the main problem with patients with liver disease is cirrhosis. Cirrhosis is a chronic liver disease, sort of end stage. It is progressive. It is irreversible. Basically what you see with cirrhosis is that functional liver tissue is destroyed. And it no longer will do the work of the liver. Typically it's replaced by fibrous scar tissue. And what you find is that blood will no longer flow through the veins in that liver. And what you get is what we call portal hypertension. Okay, the portal vein that runs through the liver. Typically you will see higher pressures, and that can cause backups. Now these are just some examples of what a normal healthy liver would look like. This is what a fatty liver looks like. And this is what a cirrhotic liver looks like. Look at the difference in the size. Okay? Yeah. Put that on the grill. Basically with cirrhosis, there are several different types. The most common type, however, is alcoholic cirrhosis, where you see that people that with a long-term abuse of alcohol causes those metabolic changes to occur. Cirrhosis can also be caused by biliary problems, meaning that somehow there is obstruction of the bile duct between the bile duct and the gallbladder and the intestine, and that bile flow gets backed up. Okay. post-hepatic cirrhosis, we're going to talk about hepatitis in a few hour or so. Hepatic cirrhosis, basically what you see is that there may be damage to the liver, typically from hepatitis B or hepatitis C. More likely hepatitis C. Chronic viral hepatitis, either B or C, is the most leading cause of post-hepatic cirrhosis in the United States. In fact, hepatitis B and C basically now, for the first time, have outstripped alcoholic cirrhosis as the biggest cause. One of the things that we're starting to see, and the new recommendation is that baby boomers be tested for Hep C, because a lot of people can have it without having outward symptoms. With cirrhosis, clinically what you see is that the liver may be enlarged, it may be tender, meaning that if you sort of palpate, you may get a pain response. Typically, you will also see weight loss, weakness, and anorexia. Okay? And some of that anorexia is due to the enlargement of the liver, sort of taking up space in the abdomen. A lot of it is also due to the buildup of the toxic waste fluids. Typically, as cirrhosis progresses, what you're going to see is manifestations related to liver cell failure. And what do you think those might be? Jaundice, high level ammonia, ascites,
Increased bilirubin.
decreased bilirubin, clotting problems. Okay, very good. The other thing you're going to see is that portal hypertension. Okay, and portal hypertension, typically what you're going to see with that is going to be what we call varices, esophageal varices. Okay? Think of esophageal varices as hemorrhoids of the throat, because that's exactly what they are. They're bulging of blood vessels so that you have a sort of outflow, and they can be very tender and they can bleed very easily. Okay, and we'll see some of varices in a little bit. Typically what you will see with cirrhosis is that hopefully what we do is treat the symptoms. Really, there's not that much that you can do to treat the cause. And typically a lot of these people will progress to liver failure. Basically what you will see with them is to try to reduce the complications. Now, what you will see whenever we can term these patients as decompensated, meaning they're in the later stages of that cirrhosis. The portal hypertension. You will see splenomegaly. Okay? Basically, what you will see is that enlarged spleen is caused by shunting of blood. Okay? Remember, what does the spleen do? It's also a filter. It basically filters out the old or dying red blood cells, white blood cells, platelets, etc. Okay? If I get more blood to the spleen, what is that going to do? It's going to cause anemia because it's going to filter more red blood cells out. Okay? So with not only are you going to see patients that have an anemia, okay, because the liver is no longer able to store iron or magnesium, what's going to happen with any red blood cells that are produced? They're going to be immature, and they're not going to have the iron available for them to be able to develop that hemoglobin and carry oxygen. Okay? So what you're going to see is sort of a cascade of problems. Typically what you also see with your patients with decompensated cirrhotic manifestations are those ascites. You also see hypoalbuminemia and hyperaldosteronism, meaning that you have low albumin levels, which makes it difficult to keep that blood into that venous system. Okay? Typically what you will see with your patients with that low albumin is that they do what we call third spacing. Okay? Meaning that that goes into the abdominal cavity or into the tissue, okay, so that you can have someone with edema, edematous tissue, ascites, but they're still dehydrated, okay? So you have to replace fluid volume as well as trying to get rid of some of that edema and ascites. Now, esophageal varices I alluded to before. Typically what you're going to see with these is the big problem is hemorrhage. Okay? Bleeding esophageal varices is a life-threatening medical emergency. You can have severe blood loss and shock from hypovolemia. Typically what you'll see with these patients, they come in, they're GI bleeding. Okay? And they will basically be throwing up pure blood. It is an absolute mess, especially since a lot of these people are Hep B or Hep C positive. So you have to be careful with infection control with patients that are GI bleeding from these varices. Now, the other thing that you will see in one of the later stages of cirrhosis is what we call PSE, or portal systemic encephalopathy. This is what you see, like Nathan was saying, with that high ammonia level. Okay, typically what you will find is that because that ammonia level elevates, you're going to see changes in personality, changes in mentation. These people get squirrely as all get out. Okay? You may also see what we call asterexis, or liver flap. Basically, you have them to hold their arms out and cock their hands up. Typically, they do this. We used to say that was them waving goodbye. Okay? Because as that ammonia level increases, typically that is one of the things that you see in those last stages of cirrhosis before the liver failure occurs. Why does that ammonia build up? The liver cancer. Right. Basically what you see is that as we ingest protein, okay, basically with the breakdown of protein, you get a byproduct of urea. Okay? The liver, you get the ammonia, I'm sorry. And what you get is the liver converts that ammonia to urea, and the kidneys then are able to excrete it. But if you got a liver that's not working, it can't convert it to urea to be excreted. So what you get is high levels of ammonia. Okay? So, what you're going to see is these patients that have what we call PSE, asterexis, liver flap. Okay? This is what you see with esophageal varices. You see why I call them sort of hemorrhoids of the throat? Because that's exactly what they look like. These are blood vessels. Okay? So think about what would be some of the nursing implications with someone with esophageal varices. What would I worry about? Swallowing? So do I want them to eat Triscuits?
No. Liquid.
Softer foods, okay, something that doesn't have any sharp points. Doritos would not be a good thing. What else would I worry about? Airway.
The cough a lot, would that cause it to rupture maybe?
Coughing could cause a rupture. Vomiting could cause a rupture. What else am I going to worry about? Nutrition. They may not want to eat. Okay. These are blood vessels. So what else am I going to worry about? What about if I've got someone with a blood pressure of 220 over 110? Do I want this person to be hypertensive? No. Okay, so I'm definitely going to make sure that their blood pressure is kept under control. Okay? He looks like he's been on a 3-day drunk, but this is acidic fluid. Okay? This is not a beer belly. That is fluid. And in fact, it's really interesting that if you have them to lay on the side, you can sort of do ballottement like you do pregnant ladies. You can watch the waves of fluid go across their stomach. Okay? Why do I worry about acidic fluid other than I can have someone that's hypovolemic?
The respirations, because it's present on their lungs.
All three. Okay? What I'm really going to worry about is because this acidic fluid sort of acts like a object that's pressing on my diaphragm, I'm not going to have as good respiratory control because, very similar to what you see with your pregnant ladies, okay, I probably am going to have someone with decreased respiratory function. Okay? The other thing that I may see is, like you said, compartment syndrome and compressing on the superior vena cava. If I have someone with large amounts of fluid in their belly, it can cause compression, either aortic compression or compression of the superior vena cava. So, if I have aortic compression, what's going to happen to these little legs right here? Decreased blood flow. If I have compression on the superior vena cava, what's going to happen? You're going to have very poor blood return back to the heart, which in fact is going to do what to your cardiac output? Okay, very good. So, basically, the other thing that can happen is we can have what we call hepatorenal syndrome. Okay? Because of that cirrhosis, what you're going to see is these patients will develop renal failure. And this is one of the most common causes of death in your patients with cirrhosis, is that hepatorenal syndrome. Basically, what you're going to see is an azotemia. Which is what, guys? Increases levels of urea, creatinine, and nitrogen in the blood. Okay? Because the liver can't convert it and filter it out. You're going to see sodium retention. You're going to see agluria, which is what? Scant urine output, by definition, between 300 and 400 milliliters a day. And then lastly, you're going to see hypotension. And that basically is going to be the reason that these people will die, is that renal failure. The other thing that you may see with your patients that have this acidic fluid is spontaneous bacterial peritonitis. All right, you got this albumin-rich, protein-rich fluid sitting in the belly. Where's that bacteria going to come from? The bowel. It's the gut. Typically what you're going to see is that E. coli or whatever is in that gut as normal flora is going to migrate over into this lovely little fluid pool, and you're going to see a spontaneous bacterial peritonitis. And what you're going to see is that these people get sick really quick and become septic. Okay? All right. Just as an overview, with cirrhosis, later clinical manifestations, jaundice, esophageal varices, ascites, hepatomegaly, and splenomegaly. Okay, the hepatomegaly is due to what? Scar tissue. Splenomegaly is due to increased blood flow. You get the hemorrhoids, same reason that you get the esophageal varices, that portal hypertension. The other thing that you see is that changes in mental responsiveness and memory, and that's due to what? The increase in ammonia level. Spider angiomas, those are those little spidery looking red things on their face, neck, and shoulders. Anemia, thrombocytopenia, and coagulation disorders. Because why? The splenomegaly and the decreased iron stores, you cannot produce enough platelets and red blood cells. Coagulation disorders, decreased clotting factors, the vitamin K. Sometimes they get red palms. Basically, with men, typically what you see is gynecomastia, or man boobs. With women, you see hirsutism, which is like a hairy face. Okay? Peripheral neuropathy usually occurs with these patients as well. Now, with abdominal assessments, what you see with this are those ascites. Often what you will see a lot of times is umbilical protrusion. Their innie becomes an outie. Very similar to what you see with your pregnant ladies whose belly button sort of sticks out. Typically you will see what we call caput medusa. Okay, remember Medusa was the snakehead lady? Okay? So that what you will see with these abdominal veins is they become very, very visible. Okay? Hepatomegaly, and then one of the things that we are going to do as a nurse is measure abdominal girths. Where do you measure it? Do you measure it at the widest point? Typically what I would do is go ahead and put two little lines on either side of my measuring tape, on either side of the belly button or the widest point, so that I would measure the same place every day, and the nurse after me measures the same place. Okay, just the two little lines on either side so that you can match up your measuring tape. Other physical assessment things that you're going to want is you're going to assess nasogastric drainage, vomitus, and stool for the presence of blood. How am I going to do that? Hemocult, if it's a cold blood, but a lot of times you're going to be able to see it. Okay. Fetor hepaticus, basically it's like super bad breath from the liver failure. It either smells very fruity or musty. It's sort of like their breath smells like poop. Okay. It's even worse than it is with DKA. Amenorrhea, usually with your women. There's a lack of menses. Typically what you're going to see also, but due to that, the gynecomastia we've talked about, testicular atrophy and impotence. Bruising and petechiae in the enlarged spleen is probably from the clotting disorders. All right. Diagnostic test. Probably the test of choice is abdominal ultrasound to measure the amount of ascites. And you can see here the amount of ascites that this person has here. And you can see it's causing compression of the bowel. EGD, okay, is, remember, looking through your throat into the upper GI system. And typically it's done to look for bleeding or oozing, esophageal varices, stomach irritation, ulcers, duodenal ulceration, and bleeding. This is just an illustration of it was a bleeding esophageal varice, and you can see they put a little band around it. It's a rubber band, so that it will stop bleeding. What this band does is it stops blood flow in to that vessel. Eventually the vessel will either shrivel up and die, or it will no longer get blood flow into there. Very similar to what they do with the rubber band treatment for hemorrhoids. Okay, basically what they do on that is just stick a rubber band around those and they shrivel up and fall off. But EGD, what are some of the nursing care things that we're going to do with some that has had an EGD? Okay, they're going down the throat, so what kind of anesthesia do you think they're going to have? Nope, they're not general. Conscious sedation, usually. Alright. So they're awake. They're not really alert. They're in that little twilight sleep. What do you think that they usually do? If I'm going to put a big tube down your throat, what are you going to do with the back of my throat? They're going to numb it. Typically what they will use is like a lidocaine spray or a viscous lidocaine. Okay? Make sure your patient's not allergic. My mom is. She almost died because they sprayed her to keep her from having a little pain. Thought they were going to have to trach her. So, I've got this patient that's had IV sedation. They've had the numbing on the throat. They've done their procedure and they come back to me on the floor. What is my nursing priority? Airway. Okay? They're breathing okay. Watching for bleeding.
If they're numb, you gotta watch the bleeding.
Her point is very valid. She said you got to watch the meeting. Am I going to let them eat? No. Usually you are going to see them hold food and fluids by mouth for at least 2 hours after that procedure. And even at that, I'm going to check to make sure that they've got adequate swallowing before I let them eat. Okay? With an EGD, airway is important. Looking for bleeding because of the procedure. And then the other priority is to withhold food and fluids because of risk of compromising of my airway. These people can aspirate in a heartbeat. All right, let's talk about labs and then we'll take a break. With laboratory assessments, AST, ALT, and lactate dehydrogenase may be elevated. Okay, what's your AST level?
8 to 35.
Okay, ALT level?
10 to 35.
10 to 60.
No, this is 10 to 60. 10 to 60.
That's what the input is what it said. I took it off of that little thing. Okay, but just remember, if it's over 60, you're going to think about liver disease. Am I really concerned of knowing the exact level? No. If I know if it's over 60, then I might have some problems with some liver dysfunction. You may see serum bili levels and urobilinogen levels may rise. Basically, what you're going to see is serum protein and albumin that's going to decrease. Okay? What you're going to see with lab assessments, again, PT is going to be prolonged. Okay? Remember with PT, what we typically see is it prolonged if they're on some medication to prolong that bleeding time. Okay? So, what would we check PT for? Basically, PT-INR? Coumadin. Okay? Basically, what you're going to see is these people won't be on Coumadin. Can't be because of those esophageal varices. Plus, they have that prolonged PT time. Their platelet count's going to be low as well. Okay? You're going to see decreased hemoglobin, decreased hematocrit values for two reasons. Number one is what? The cells get destroyed because of the increased splenic blood flow. And number two, what are those varices doing? They may be oozing. You may have frank bleeding. Okay? Typically what you're going to see with your patients with those varices, not having flash, I'm having a melt. Typically what you're going to see is low H&H because of a pathophysiologic reason as well as bleeding. Okay? So one of the things that you're going to see with these patients is that if their H&H is slowly trending down, one of the things that they're going to look for are oozing esophageal varices, and they're going to do that EGD to look for those lesions. Elevated ammonia levels, okay? Serum creatinine level is going to be elevated again because they may have that incidence of renal failure. All right, ammonia. Byproduct of protein breakdown. Okay? Basically what you're going to see is that some of the drugs that alter are going to be antibiotics, alcohol, and potassium. Okay? Basically what we want to see is an adult ammonia level to be 15 to 45. Typically what you start seeing is that when they get above 60 or so, you're starting to see some confusion. Above 100, you definitely will see some confusion. So what we want is below 50 on that ammonia level. Remember, high ammonia, you start seeing that flap and confusion. PT, remember, if it is prolonged at least 2.5 times, watch these people for bleeding. Because you're going to have problems with them bleeding from those esophageal varices. All right, take a break. Basically, what you will see is that typically what what they're going to do is to treat the complications and the effects. It will not slow or stop the process. Typically what you're going to see is you're going to treat the fluid volume problems, you're going to treat the coagulation problems, you're going to treat the buildup of toxins, okay? So typically what you'll see with diuretics, they're used to decrease the amount of fluid retention in the ascites. The majority of the time they use furosemide and spironolactone, okay? One of the things I'm going to tell you guys is you need to get used to looking at generic names for drugs. NCLEX is going to only generics. They're taking out trade names. So get used to looking at those generic names when they're talking about particular treatments, okay? Basically, Lasix or furosemide. What does it treat better, fluid retention or ascites? Fluid retention, okay? Because what it does is it decreases the amount of intravascular fluid, okay, so that what happens is that fluid is sort of sucked back into the system. Spironolactone is a medication that will help with pulling some of that acidic fluid back into the intravascular. A lot of times what you will see is they will use both of these drugs. The spironolactone is done to bring that fluid back into the intravascular. The furosemide is done to, once it's in that intravascular space, for them to pee it off. Okay? But you have to be very careful with these meds. Because think of kidney function, okay? If you have someone with impaired renal function, is Lasix going to work? No. So you have to be careful with that. And often what you will find is that the longer that someone is on Lasix, the less effective that medication becomes. Now, the other thing that you will see to help with that high ammonia level is something called lactulose, okay? Lactulose is a medication that comes in sorbitol, okay? So it basically is given either PO. It can also be given as a lactulose enema. Basically, what lactulose does is that it causes the ammonia to be excreted in the bowel. And typically what you will see is these patients will have 2 or 3 or more very soft stools a day. That is the therapeutic effect. What you should see is that as they poop, that ammonia level will go down. Do not hold this medication because they poop 5 or 6 times a day. That's what you want them to do. So you definitely want these patients to have these soft stools to lower that serum ammonia level. Now, neomycin. What type of drug do you think that this is? It's an antibiotic, okay? Basically what neomycin does is that it kills the bacteria that breaks down the protein that form the ammonia. Again, PO or by enema. What you typically do not see is both of these be given at the same time. Neomycin, usually what you will see is they will have limited use because it is an aminoglycoside and it can cause what? Nephrotoxicity, ototoxicity, and all sorts of other problems. So typically they don't leave them on that medicine long term. However, the lactulose, they will continue to, this can be as long as they need it. Okay? You usually don't see both of them at the same time. I love the gas mask. But typically what you will see is lactulose given to decrease that ammonia level. Now, another med that you may see them on is Inderal or propranolol. Basically, propranolol is a what? Beta blocker. What it does is that it lowers that portal hypertension by lowering the blood pressure. What else do beta blockers do? Decrease heart rate. So typically what you're going to see is there is probably a lessened chance of having bleeding from those esophageal varices because of the lowered blood pressure, the lowered portal hypertension, and the lowered systemic blood pressure, and the decreased heart rate. Okay? Other meds that you will see are ferrous sulfate or folic acid. Remember, the liver is no longer able to store iron. Typically what happens is that when the spleen breaks down those red blood cells, that iron is stored in the liver to be recycled, so to speak. Plus we get the iron from our food supplies. Well, what you can't do when the liver is damaged by that cirrhotic scar tissue is store that iron. So you have to have a supply of iron and folic acid to be able to make those red blood cells and make them workable. Okay? Antacids may be used, especially if they have GERD. And basically that's to keep the acid from that esophageal varice tract. Typically Cirax or Oxapam, okay, it's a PAM, which means that it's an anti-anxiety medication, okay? Remember, Valium is diazepam, okay? So what that does is it helps with some of that acute agitation, and that can be used to treat someone with ammonia levels that are too high. What you have to be careful about, though, is that you don't want to give them too many narcotics or opioids or benzos, because what breaks those drugs down and metabolizes them? The liver. So if I'm giving someone a lot of a benzo or a lot of an opioid, what is that patient at risk for? Toxicity. Okay? Now, other drugs that you will see, it will depend on what the reason for the specific cirrhosis is. If it is due to hepatitis B or hepatitis C, typically they will do antivirals to try to decrease the viral load to limit the amount of damage that's done to that liver. But that typically is only done if it is due to a hepatitis. Now, nutrition-wise, typically what you're going to see with these patients is we want to limit sodium. Sodium is limited to 1.5 grams a day. Okay, so that it's lower sodium than some of your cardiac patients, right? because they get 2 or 2,000 milligrams. Why are we limiting sodium? Fluid follows sodium. Okay, so if we limit that sodium intake, what we hope to decrease is the amount of edema and the amount of acidic fluid, or the ascites, that's built up. Okay, so low sodium diet. Typically what you're going to see with someone that doesn't have a problem with ammonia, protein is not regulated. But if they have a problem with that ammonia buildup, they will get a very low protein, or sometimes even eliminated, because remember, it's the breakdown of proteins that cause that ammonia to form. High calorie, moderate fat. Moderate fat. Okay? That can be a problem. Because nothing tastes better than a little fat. A little butter on your pancakes, a little butter on your grits. That back in a biscuit. Cracklings in a biscuit. Alright. Other things, of course, you're going to see vitamins and mineral supplements, B complex, fat solubles. Remember, because we don't have liver function, these are going to be absorbed less. Remember, vitamin K should be on there as well. Patients that have alcoholic-induced cirrhosis often need magnesium, because their magnesium levels are going to be low. And why do I care about magnesium? The heart. Yeah. Remember, it needs magnesium to make sure that it has that regular rate and rhythm. Okay? Now, with patients with cirrhosis that have progressed to liver failure, typically they may, depending on what the patient's comorbid medical conditions are, they may do a liver transplant. Basically, these are the indications: functional decline, increasing bilirubin, decreasing albumin, and increasing problems with complications. Those would be your varices. Those would be your portal systemic encephalopathy, etc., etc. The contraindications to transplant would be a malignancy. Okay? If they actively are using drugs or alcohol, it just blows me away that David Crosby got a liver transplant. Because I know this guy had to stop. Or if they're a very poor surgical risk. Okay? But typically what you will see with transplant of the liver is that they will sometimes do a whole liver transplant from someone that has done organ donation. However, now what they're starting to do more and more is like a donor, where you basically would go in to your donor, resect half of the liver, transplant it into your patient that needs the transplant, and typically what will happen is that the liver will grow to the regular size in both patients. So what they're doing now is more living donors than they are organ donations. But transplant would help. Now, it depends on what the reason for the transplant was. Okay? If it is due to hepatitis B or hepatitis C, typically what you will find is that eventually that liver will also become infected and eventually will go down the path of failure again. However, if it's due to alcohol or drug abuse and that person has stopped, that liver may function for the rest of their natural life. Okay? Now, the other thing that they may do is called a TIPS procedure, a transjugular intrahepatic portosystemic shunt. That's why it's called a TIPS. Okay? Typically, these are performed in interventional radiology. Patients consciously sedated again. La la land, so to speak, so that what happens is that your interventional radiologist puts a line in the jugular vein and that stent is placed in the portal vein to keep it open. So that what you see is that the stent is right here in that portal vein. And what that does is it reduces the portal hypertension. Typically what you're going to find is that these patients are kept in the hospital for maybe 1 to 2 days after this procedure, typically followed by ultrasound about 4 to 6 weeks after the procedure, and then again for over a year. Okay? About every 6 months for the first year. A lot of times this will decrease some of the complications that you see. So TIPS is a non-surgical procedure that you may see done. Nursing diagnoses that you're going to see as priority are these: excess fluid volume, risk for acute confusion, ineffective protection, impaired skin integrity, and imbalanced nutrition less than body requirements. So, for excess fluid volume, it's very similar to what you're going to see with your patients with cardiac problems with excess fluid. We're going to weigh them daily. We're going to assess urine-specific gravity. So tell me, does urine-specific gravity go up or down?
Down.
If I have, let me finish the rest of my question. Does it go up or down if I have that hepatic renal dysfunction syndrome? Because urine becomes more concentrated, okay? All right, remember, urine-specific gravity is higher if it's concentrated. The closer it is to 1.000, that basically is free water with no electrolytes in it. Low sodium diet and restrict fluids as ordered. Typically, they don't restrict fluids very much. They prefer the sodium to work with that. Acute confusion. This is where we worry about that ammonia level. Okay? So we want to make sure that we are monitoring their ammonia level. We want to make sure that they are kept free of drugs that may increase their confusion because of the poor metabolism. Your opioids, your sedatives, your barbiturates, your benzos. Assess for level of consciousness and confusion. Typically when you have patients that do have that encephalopathy, consistent nursing assignments, working with a consistent nurse, basically works 2 ways. Number 1, you know when that patient is getting a little worse. And number 2, that patient knows that consistent face, and it helps decrease some of their confusion. Okay? Moderate protein diet or restricted, depending on what their ammonia level might be. And you need to teach the family the importance of those diet restrictions. Because if you have this wonderful diet for them while they're in the hospital, but don't teach the family the importance of that moderate to low protein diet when they go home, what are they going to do on the way? Go through Bojangles drive-through, and you've just killed their sodium restriction and their protein restriction. Okay? Especially if they get the gallon of sweet tea to go with it. Meds and enemas. Remember our meds that we're going to give to help with that ammonia level or what? Lactulose, neomycin. Continually orient them to person, place, and time. Okay? Again, this is what you see with that PSE syndrome. Okay? Hyperreflexia. And we're talking about deep tendon reflexes there. Okay? Ineffective protection. And I'm talking, this is bleeding that I'm worried about right here. Ineffective protection, risk for bleeding may also be one of your nursing diagnoses. Monitor vital signs, bleeding precautions, which are going to include what, guys? Soft toothbrush, soft foods, no razors. What else might I want to do to assess for bleeding? Hemocalls. All vomitus, all stool should be checked. Okay? We're going to monitor our coagulation studies, PT-INR. We're going to monitor platelet level. We're going to monitor H&H. And I don't care what they are today. I'm going to compare them to yesterday and the day before because you're looking for trends. Any lab that you assess, look for the trend because that's going to give you the bigger picture. Okay?
Would you want to put a central line in so you don't have to do a bunch of needle sticks? Or?
That may be an option depending on how low their counts are. But think about this. You know, you're sort of damned if you do, damned if you don't. You put a central line in them, they're at greater risk for bleeding and oozing from that central line as they would be from their labs. An infection. Right. So it's one of those balancing things. The other thing is that more than likely you're not going to draw everyday labs on these folks. So maybe every other day, every third day. Because unless you have a major event like a GI bleed, then it's probably not going to change that much significantly. Okay? Impaired skin integrity. Remember what Ms. Rumble talked to you about with your patients with renal, where they have that itchy skin? Typically, your hepatic patients will also have that very, very dry skin. If indicated, apply mittens to their hands to keep them from scratching, just like you do with babies. We want to make sure that they don't have skin breakdown. Antihistamines, maybe. Okay, remember diphenhydramine or Benadryl has a sedative effect as well, and they may not be able to clear it from their liver as well. So you have to be careful you might want to only give 12.5 instead of 25 of Benadryl. Yes?
Would this cause like the bile salts, like
It could.
so they get pressed on for that, possibly?
I've not seen that, but it could. I mean, typically you see that more with your renal patients, with the uremic frost, the urea. I don't know that, I've not seen it with patients that I've cared for. But they do itch like the dickens. Imbalanced nutrition, again, daily weights. Low sodium, high carb, moderate fat. High protein unless their protein is restricted. If they're starting to have problems with their ammonia, you're going to do moderate to low amounts of protein. Typically what you're going to see is small meals with snacks. Why am I going to do small meals and multiple snacks? Well, they digest, their GI system is working, they can't absorb it.
The Ascites is not going to make it anymore.
Very good. Okay? Those of you that have been pregnant know what she's talking about. You got this big belly, you can't eat that much. So what you're going to see is that the amount of ascites that they've got is going to cause abdominal pressure, and they're going to feel full very easily. So what you're going to do is multiple small meals throughout the day in order to keep their nutritional level up, because the amount of food that they take in is decreased. Typically, you're always going to have a consult with the dietitian, not only for in-hospital, but for dietary teaching for home. Okay? Now, management of some of the complications. Paracentesis. Paracentesis, basically, what they do is they go in and, with a trocar, and aspirate the fluid. Okay? So that what you're going to typically see is that they may go down. Typically, they are sitting in a sitting procedure, because you don't want the fluid sort of spread out. You want it sort of sitting up so that you can get to it very easily. The other thing that you're going to see is that you want to make sure that it's done under ultrasound so that you're not jabbing someone's guts out. Okay? Now, what we're talking about nursing care for paracentesis, if you're either assisting or preparing someone for paracentesis. Basically, we're going to explain procedure and answer questions. Vital signs, including weight and abdominal girth. Okay, remember, checking that belly. One of the things you're going to want them to do is void prior to the procedure, because if you've got a big bladder, what is that going to increase the risk of? Puncture of the bladder. Okay, so we don't want to. We want that bladder empty. We're going to elevate the head of the bed, and we're going to monitor the vital signs during and after the procedure. Any of you ever taken care of someone with paracentesis? How often were the vital signs when they go back to the floor?
I didn't sit there 15 minutes.
I got witness and did a procedure with them. They were checking on
The whole time. Typically, what you're going to see when they get back to the floor is vital signs Q15 times 2 hours, Q30 times 2 hours, Q1 times 2 hours, etc., etc. Okay? Why am I checking those vital signs that often?
Too much fluid can cause hypovolemia.
Right. She's exactly right. If I pull off that fluid, okay, they can have a fluid shift from the intravascular into the abdominal cavity again and go into hypovolemic shock. The other thing is that you hope that they haven't punctured anything, okay, so that you are also checking for hypovolemic shock from blood loss. So you definitely want to do those vitals fairly frequently, whatever the protocol might be. Okay? Basically, what you're going to see is that after the procedure, we're going to weigh that client and measure that abdominal girth again, and hopefully it has gone down. They typically are on bed rest for a few hours after this procedure. Okay? Now, the other thing that you may see done, and it depends on your physician, though a lot of the people that I've worked with do this, is that the reason that they have this fluid to go out into their belly to begin with is low albumin levels, right? Okay? So a lot of the docs will give them albumin either prior to the procedure and after the procedure, hopefully to increase the amount of albumin they've got on board to try to hold some of that fluid in. Okay? Typically what you're going to see is they will only take out 1,000 to 2,000 cc's of fluid. Taking out more than 2,000 cc's of fluid, again, can cause hypovolemic shock because you get a rapid influx of that intravascular fluid back into that belly. Okay? Now, how often do you want to do this? Do I want to have to stay in the hospital or come someplace every day to get paracentesis done? No. Often what they will do is what they call Plurex. Okay? Plurex is a semi-permanent catheter. Not only can it be done for pleural effusion, which you see it most often for, but Plurex can be done for acidic fluid. Okay? What they do is they teach the family, there's a port, they teach the family under aseptic technique how to hook up this drainage system, drain off fluid, and then however often that they need to have this done, the family would do it, or the home care nurse would come and do it. Okay? Complications: hypertension, circulatory collapse, electrolyte imbalance, protein depletion, ascites, leakage, peritonitis, wound infection, loculations of the peritoneal space. What the heavens is that? What is a loculation? Basically what it is it's like scar tissue that forms in there. Okay? Again, no more than 2,000 milliliters at a time. But Plurex is something that they've started doing with people that have to have fairly frequent paracentesis. Now, one of the other things, of course, that you're going to remember is that acidic fluid can cause respiratory problems, and we've talked about that. Elevating the head of the bed 30 degrees or as high as the client wants it. You're going to want to make sure that they have oxygen if needed. And if you're doing daily weights on these people, and you should be, you want them in this standing position. Okay? Not trying to balance on one of those little doctor's scales, but one of the ones that you can stand on that's got the handles to it. Okay? Alright. What did I forget? Alright, let's go with esophageal varices. Now, typically what we want to do with bleeding esophageal varices is restore the hemodynamic stability. In other words, make sure that the bleeding stops. Okay? Typically what you're going to see is that they will do an EGD or an endoscopy to evaluate and treat. They may put in a large bore nasogastric tube and do what we call ice water lavage. Okay? Basically what that is taking iced saline, infusing it via that NG tube, and then immediately sucking it out. Okay? Because what does cold do to blood vessels? It vasoconstricts. It's not like you can take your hand down their throat and hold direct pressure on there. Okay? So ice water lavage is one of the ways that we can vasoconstrict and try to decrease some of that bleeding. The other thing, of course, is with an EGD, they can be banded. Remember that little rubber band or that suture, or sclerosed. Basically, they would do like a cautery or an injection to sclerose that thing. Now, the other thing that they will do is a balloon tamponade if the bleeding is uncontrollable. And what that usually is this tube that we call a Blakemore tube. Now, I would suggest that if you've got someone that needs a Blakemore Stanstein tube, they definitely need to be in the ICU. Because number one, I am going to want this patient intubated to make sure that my airway is protected. Okay? Because what I'm going to do is when that tube is put into place, it's a triple port. And what it does is there's a gastric balloon that's blown up to keep that tube in place. There's a balloon that goes up the esophagus to cause that direct pressure, like we do with a wound, to stop bleeding. So what this does is it causes that direct pressure. You're also able to suction to get that blood out of the stomach. Okay? Now, why am I worried about protecting my airway? What if this tube slips? What's going to happen? It's going to cut off their airway. Okay? Can't breathe because the balloon is inflated. Emergency equipment for this piece of equipment is a pair of scissors. You cut the ports to pull out the tube. Now, if I do have to do that because my airway is not protected, my bleeding is going to be uncontrolled as well. So again, you're sort of between a rock and a hard place. That's why it's better to have these people in the ICU with an E2 tube in place. What I will tell you is that these people usually are not left alone. When we're talking one-on-one care, we're talking one-on-one in the room. Okay? Because of the potential for airway compromise. Questions about this? Don't see them used that often. It's sort of one of those last ditch type things. But airway protection is one of your priorities. Y'all want to take another break and then start on hepatitis? Okay.
No, I prefer 30 minutes. I might be done.
All right, so hepatitis. Hepatitis is widespread inflammation of liver cells. Basically what happens is it results in degeneration and necrosis. Basically what you're going to see specifically with hepatitis B and hepatitis C, it can develop into cirrhosis. Basically what you're going to see with those two strains of that virus is that typically the damage is irreversible and it can lead to liver failure and death. Basically what you'll see, I've got up here all these different letters. When I first started in nursing, we had hepatitis A and hepatitis B. And then a couple years later, it came out with hepatitis not A, not B, because they didn't know what it was, so they eventually named it hepatitis C. Now we have D and E. There was a possibility there was an F, but F sort of got quenched. That's not really a virus. But now they're looking at G and H. So Lord only knows when the time you guys retire from nursing how many letters of the alphabet there will be of hepatitis. What you typically see with hepatitis is that the majority of the time when you're talking about it, you're talking about viral hepatitis. Though hepatitis can be toxic or drug-induced, a lot of herbs will cause drug-induced hepatitis. It can also be secondary to a lot of other of the viral infections, specifically Epstein-Barr, herpes simplex, varicella, or zoster, or cytomegalovirus. Okay, all of those are viral infections that cause a secondary hepatitis infection. One of the things that you will see is that hepatitis is one of those required reporting. Okay, it has to be reported to the local health department, and then the local health department notifies the CDC. Now, let's go through the different types. Hepatitis A, okay? Basically, it's very similar to a viral syndrome. A lot of times you'll see people have hepatitis A. It does not get recognized, and it most of the time will go away without any damage. Basically, it's a very hardy virus, and it can live and on areas it's very resistant to detergents and acids. It is destroyed by pouring the bleach at high temperatures. It's basically oral fecal route. Okay, so anything that is contaminated by feces may induce hepatitis B. It can also be transmitted by oral anal sex. Okay. Incubation period is about 15 to 50 days. And basically, typically with A, it's not life-threatening. It's fairly self-limiting. No treatments necessary. It usually just sort of goes away. As you can see, some of the at-risk populations, military personnel, children in daycare, male homosexuals, HIV-infected people, and travel to third world countries. Vaccination is the most effective means of preventing it. And what we're starting to see is that hepatitis A vaccine basically is a recommended vaccination now for children at about age 1. Most of us have not been immunized for hepatitis A unless you specifically ask for it, or you've gone overseas, or you've been in the military. They will vaccinate you for it. As you can see, oral fecal route. A lot of times what you will see contaminated shellfish. One of the things that you really worry about is contamination, sewage spills into streams in our water supply. One of the things you also worry about is infected workers at restaurants. That is why it is a law that employees must wash their hands after using the bathroom. Now, if they do a half-assed job of it, it doesn't really help. But what you want is that someone that's preparing your food to be hepatitis A free. Okay? One of the things that I can remember is that early 80s, the food at Duke was horrible. Absolutely horrible. So everyone would order from Pizza Hut. And it would be nothing for there to be, this was just when delivery of pizza started. And Pizza Hut had one dedicated actually they had 3 dedicated drivers that delivered pizza, because it would be nothing for them to deliver 200 to 300 pizzas an evening to Duke, a night. Well, guess what happened? One of the food preparers came down with hepatitis A. So we had to have a clinic in the cafeteria to immunize us all for hepatitis A and give us the immunoglobulin to prevent hepatitis infection in 700 healthcare workers at Duke. How many of you remember about a year or so ago, the pizza place over at University City came down with someone with hepatitis A? Okay. It was like all over the news, and I mean everyone that had ever eaten pizza, let alone whether it was from that particular restaurant, was in line to get vaccinated. Okay? Hepatitis A, again, oral fecal route. Self-limiting, typically it goes away as a viral illness. Now, that's different than hepatitis B. Hepatitis B, basically, typically what you see is unprotected sexual intercourse with an infected partner, shared needles, accidental needle sticks, blood transfusions, typically before 1987, hemodialysis. A large number of your patients that are on hemodialysis are Hep B positive. It can be transmitted maternal fetal route. Typically that's more in undeveloped countries though. Typically with Hep B, you see symptoms develop 25 to 180 days. Okay, 180 days is almost half a year. Basically what you'll see, anorexia, nausea, vomiting, fever, fatigue, right upper quadrant pain. Okay, why do you see right upper quadrant pain? It's where the liver is. Dark urine, light stool, joint pain, and jaundice. Why do you see the light stool?
Dealing with the liver decrease.
Right. There's no bile to cause the darkening of the stool. Basically, what you will see is that 40% of people with Hep B have no symptoms. Scary, scary thing. They don't have any symptoms. What you see is that a lot of people recover, clear the virus, and develop immunity. However, there have been some people that have chronic Hep B infections. One of the things that has greatly reduced the number of Hep B positive people is the vaccinations. Okay? Used to be, whenever you worked in healthcare, only people that were exposed to a lot of blood, i.e. your emergency department people and your ICU people, got Hep B vaccinations. Well, then they sort of changed the tide, and, well, all healthcare workers should be vaccinated against Hep B. Now, it is one of the vaccinations that is required for children. Okay? Typically, what you're going to see is that Hep B vaccinations is a series of 3 over about 6 months. You guys got them. 1 month, you get a shot. 1 month later, you get another shot. 6 months later, you get the 3rd shot. Okay? And typically, that's enough to raise the immunity. So what we're seeing now is, because more and more people are becoming vaccinated against hepatitis B, we're starting to develop a herd immunity, so to speak. Okay? So that you see less and less Hep B positive. Hep C. Hepatitis C is the most chronic blood-borne infection in the United States. Spread by sharing needles, tattoos, intranasal cocaine use, blood products, organ transplants prior to 1992, and needle stick injury. Okay? Hep C is not caused by casual contact or intimate household contact, but people that have hepatitis C should not share razors, toothbrush, pierced earrings, etc., because of microscopic blood. I'm sorry, but I'm not sharing my toothbrush with anybody. No matter who you are, if you use my toothbrush, you can have it, because I will get another one. Anytime there is the chance of blood contact, that's what you have to worry about. Typically what you're going to see with hepatitis C, again, is that sometimes they're asymptomatic, and that damage can occur over several years. That's why one of the recommendations is out there that everyone baby boomer age be checked for hepatitis C, because again, a large amount of people are asymptomatic with this disease. Basically, it is a chronic infection, and typically it does lead to cirrhosis. And as I said, it's one of the leading reasons for liver failure and liver transplant. Basically, what you're going to see is that IV drug abusers and healthcare workers are at risk for hepatitis C. With hepatitis B and hepatitis C, I've talked about needle sticks. One of the things that you need to make sure that as a healthcare provider that you're doing is that if you do get a needle stick, that you are tested immediately and fill out those incident reports and make sure that they're following through, because they will continue to test you for at least a year to make sure that you don't develop that infection. Okay? Hep B. Hepatitis D, you can only have D if you have B. Okay? Because it is basically a co-infection. And hepatitis D needs the presence of hepatitis B for viral replication. D is an incomplete viral strain. It's basically primarily by parenteral routes, blood-to-blood contact, incubation periods 14 to 56 days. All right. Hepatitis E. Again, it's oral fecal. It's mostly in contaminated water. Okay? Basically, what you're going to see is endemic in areas where you have waterborne, like mostly Southeast Asia and Africa. Sometimes in the lower portions of Mexico. Okay? So don't drink the water is really a good advice. There's no FDA approved vaccine for hepatitis E. There's no vaccination for it. Basically what you will see is that it's a very serious liver disease that usually results in acute affection. Hepatitis E can cause maternal fetal death, again, mostly in Asia, where it occurs. Now, one of the things that I remember about hepatitises is this little saying, hepatitis with a valve comes from the bowel, A and E, or oral fecal. Everything else is bloodborne. Okay? Hepatitis with a vowel comes from the bowel. Now, when you look at those, again, Hepatitis A, there's a vaccine. It is now standard. If you have not had hepatitis A, I'd recommend it the next time you go for your doctor visit. It's not one of the ones that we recommend, that we require coming in to school, though. There's no vaccine for E. B, again, there is a vaccine for B. C, no vaccine. D, no vaccine. So A and B have vaccines available to prevent. Signs and symptoms doesn't really matter what type it is. What you're going to see is that right upper quadrant: discomfort, nausea, vomiting, anorexia and weight loss, fever and chills, sort of like a flu-like disease, jaundice, and then that dark urine. Okay? Basically, they diagnose it by doing blood tests, looking for that specific antibody or antigen. Okay? It's just a blood test. All right. Infection control, sanitation, hygiene, good hand washing. All right. That happy birthday song. Happy birthday. Making sure it's twice. Okay, we want a good hand wash. Making sure that safe water is used. Okay, that's not been contaminated. Remember that shellfish, like oysters, are filter feeders. And so, if there is a sewage contamination, they're more likely. That's why there's this big warning on eating raw oysters that contaminated shellfish may cause Okay. Condoms. Remember, hepatitis C can be transmitted via semen. So condom use is very important, or abstaining from sexual contact with someone that's actively infected. Making sure that people that have had hepatitis B or C, they never donate blood, organs, or body tissues. Okay. Universal precautions for everybody. Okay. And they use basically needleless systems, have decreased the incidence of needle sticks with healthcare workers. Hopefully will decrease the amount of healthcare workers that get hepatitis B or C. Basically, with post-exposure prevention, they need to seek medical attention. Basically, what you will see with if they've been exposed to hepatitis B. Typically what they will do is if they have not had the hepatitis B vaccine, give them the vaccine. And then they will give them the hepatitis B immunoglobulin. Okay, it's like a immunoglobulin that they will get to help prevent that viral infection. All cases need to be reported to the local health department. Not your job to report them. Typically, it's a physician to do that, unless it's part of your job description, other than just a regular staff nurse. But basically, there is a duty to warn people that have been exposed to hepatitis so that they can get that vaccine. Clinically, what you see, we've talked a little bit about arthralgia or joint pain or myalgia. Again, these people sort of feel like they've got the flu. Management, typically what you're going to do is put them on bed rest. Okay? Because because of those myalgias and arthralgias, they feel really bad. What you want is rest to help repair that liver. Diet therapy, typically high in carbs and calories, moderate amounts of fats and proteins, okay? Again, because the liver is not able to worry about that ammonia. You want to decrease the amount of ammonia made to help them, that liver to rest. Typically what you will see is antiemetics like promethazine or phenergan or compazine, okay, to help decrease some of the nausea. Typically for B and C, if they have a chronic infection of hepatitis B or they have hepatitis C, they will give them antiviral medications. The Epivir or the Hepcera, and these will be medications that they will stay on. And that will help decrease the replication so that hopefully they will not develop cirrhosis. Now, what you may see is that with these antivirals, some of your people with hepatitis C may be on interferon therapy, okay? An immunomodulator that helps to decrease the amount of damage that's done with that hepatitis C infection. Client educations, if you have someone that has hepatitis, basically you need to teach them to avoid all medications, whether it's prescription or over the counter, while they have that active infection. Because what you're going to see is that metabolism of those drugs may be altered, and you may have someone that has a toxic effect. Again, avoid all alcohol. Liver's not able to metabolize it. Rest. Again, small, frequent meals. And they're asked to avoid all sexual contact until their antibody tested results are negative. Now, if you're talking about someone with chronic hepatitis C, that's not a reasonable request because they're going to have those high antibody levels because it's a chronic infection. But if you have an uninfected partner, then what you want to do is make sure that you use universal standard precautions and that condom use is always, safe sex is always followed. Basically, what we want to do is to make sure that they follow the guidelines for preventing transmission, not only to their family, but to others. If someone is hepatitis A or E, okay, and they work in a restaurant, they definitely cannot go back to work until they're antibody negative, okay? Even if they wear gloves, the chance of infection for the rest of the public is there. Okay, so typically they will not let these people work until they're antibody negative. Questions about hepatitis?
He wants to know this information.
Just FYI, in case you ever get touched. Cancer of the liver. Basically what you're going to see is primary tumors, or the majority of what we're going to see here in the United States are going to be metastatic tumors. With primary tumors, the hepatocellular carcinomas, you will see mostly in Asia and the Mediterranean. Though what I've seen is that Black and Hispanic populations have twice the rate of primary liver cancer than any other population. Adults are usually affected, and if you have a chronic infection of hepatitis C, it greatly increases your risk for liver cancer. Now, what we will see most of the time in this area is metastatic liver cancer. Typically, one of the things that you see is that if someone works in healthcare and then someone says something about mets to the liver, you get the face, because they know that metastatic disease to the liver has all of the problems that we see with cirrhosis, with the ammonia buildup, the problems with coagulation, the problems with fluid. Very similar to what you see with cirrhosis, these people progress to liver failure. Cancer of the liver, basically, when you're talking about chemotherapy, a single dose or a single method chemotherapy is not that effective, and typically you're going to see these people on 4 to 5 different chemotherapeutic agents. However, the way that the research that I've done is that even with the 4 to 5 agents, the effectiveness is not that very good. Liver transplant, we alluded to when we talked about cirrhosis. Basically, what you're going to see is that they will do very extensive physiologic and psychological assessment. With liver transplant, cardiovascular instability or with advanced cardiac disease, i.e. coronary artery disease, or if they've had MI, probably are not candidates. Severe respiratory disease like COPD, not a candidate. If they have metastatic tumors to the liver, or they have the inability to follow instructions regarding therapy and self-management. And along with that, it doesn't really matter whether it's a liver transplant, a kidney transplant, any type of transplant. If these people are not able to follow the instructions for drug therapy and self-management and able to afford those medications, okay? Because we're talking thousands of dollars for these immunomodulators and rejection drugs, then they are not candidates for transplant, okay? Typically, like I said, the majority of your liver transplants now are split liver, where a portion of that liver is removed from your donor and then transplanted into the recipient. And typically that liver tissue will grow to the size that it needs to be. All right. Questions on